afternoon, everybody. My name is Bob Perry. I'm from WM UK, the WM branch in the United Kingdom. I'm a WM patient. I've been living with the condition for 6 years. I had chemotherapy 6 years ago, 8 months worth of bendamustine and rituximab, and now I'm on active monitoring and living a very nice life here on the south coast of England in Bournemouth, where I live with my wife, Deborah. Today, I have the great pleasure of introducing Dr. Shirley Desar. Shirley is a consultant haematologist and associate professor at University College London Hospital, the NHS Foundation Trust. And she's going to talk to us this afternoon about a most critical WM complication that I hear a lot of people suffer from, thankfully not myself. She's going to talk to us about peripheral neuropathy. At the end of Shirley's talk, she'll take a few questions from the audience. So with no further ado, I'm going to hand over to you, Shirley, Dr. Shirley Desar.
I'd like to welcome everyone and just make a slight correction to what Bob said. I'm a consultant hematologist. I think he made a Freudian slip and called me a neurologist, but I do work very closely with neurologists. And it's a great interest of mine, trying to work out and manage patients with Waldenstrom's and related conditions and neurological problems. So yes, good evening from me here in London, and it's good to see everybody. It'll be lovely when we can actually meet face to face at some stage. I hope this evening finds you all well. The best thing to do is to start with a quick tour of the nervous system. And that's what I'm going to do. That's just an introductory slide. So basically, the nervous system consists of the central nervous system, the CNS, which is the brain and the spinal cord, and the peripheral nervous system, which is how the brain communicates with all the other tissues of the body. And let's face it, the brain is in charge of everything we do, consciously or unconsciously. And in order to communicate effectively, electrical communication needs to be super fast and, sub-second in terms of speed. And how does this manage? Well, the system manages this by nervous tissue that imitates electrical wiring. So if we go to a smaller level, we can see that the nerve fiber here. So what we have, looking at the nerves in more detail, is that in order to get the signals all the way down from the brain into the distant areas of the body, there needs to be a lot of backup tissue to support the nerves throughout their function. And this backup tissue consists of cells called Schwann cells, which wrap themselves around the so-called axon, which is the actual wire of the cell, and forms a supportive layer which helps to allow the conduction of the electricity to go very, very rapidly. And these Schwann cells form what are called a myelin sheath, which many of you will have heard about because myelin does feature often in people with IgM-related problems. And you can also see here, there are blood vessels that supply the nerves. And that's another area that if that goes wrong in some way, then the nerves don't get what they need and they then begin to degenerate. So the anatomy of a nerve is actually very crucial to the way it functions. So looking at motor nerves, which are the ones that supply muscles with electricity so that they can contract, you get signals sent from the brain to say you need to contract this particular muscle. It goes down the axon, assisted by the myelin, into the nerve fiber, the muscle fiber, via what's called a neuromuscular junction. Those signals result in muscle contraction, and muscle contraction results in movement. Sensation is kind of slightly the opposite. So you get a variety of stimuli which send either pain, pressure, temperature, joint position sense upwards towards the brain so that the brain can sense what is going on. And again, you can see that if things are not working so well, it could be at any level here that there is an interruption in the communication pathway. So some stimulus, you can have a problem with the stimulus coming to the skin, or it's higher up on the nerve or in the cell bodies, etc. So that's the sensory system. There is then this other system called the autonomic nervous system. Another word I like to use for it is the automatic nervous system, which basically is the nervous system that's ticking away behind the scenes to let all our organs work. There are two sort of categories, one called the sympathetic nervous system, which deals with so-called fight or flight reactions, and the other called the parasympathetic system, which deals with so-called rest and digest. And these systems swing into action depending on what's going on with us, and they do a lot of things behind the scenes, and it's only when they don't work that we actually realize what they do. So that's the autonomic nervous system. So when things go wrong, you can see, therefore, that actually when this pristine system, the physiological state, is not working properly, and there is a disruption to the nerve fiber for whatever reason, and we'll come on to those in a bit, you can understand clearly that the electricity will not go as it's meant to go. It'll be slow, it'll be interrupted. Messages will be mixed, so sensation will change, coordination will change. You can get other symptoms like tremor. And you can see that this very careful, well-designed system can go wrong without, in fact, it's amazing how it continues to go right for a long time. And the reason is that if you lose the odd axon, you can compensate. But if you lose many axons over time, then this can lead to a gradual buildup of deficiency in function. What about the myelin sheath? Well, as I mentioned before, the myelin sheath helps not only to support the nerves physiologically, provides them with nutrition and oxygen and everything else, it also helps to insulate the nerves. So when you get so-called demyelination, this sort of sheath, the insulation is lost, and that disrupts the flow of electricity. So demyelinating neuropathies, which are quite common in Waldenström's, are another important feature that one needs to be aware of. And you can see why, actually, when the myelin is lost, the most distant part of the nerve is affected the worst, because that's the bit that is furthest away from the cell body. And so by the time it gets whatever it needs, there's not much left. So if you think about the sciatic nerve, is about 1 meter long in some people. By the time you get to the bottom of that nerve, that is why you can get so-called length-dependent neuropathies. The further away the nerve is, the more likely damage can be to it. With the autonomic nervous system, you may feel a variety of other symptoms. And I mention these not to instill fear or concern, but just to highlight the kind of things that if you find are happening increasingly, recurrently, it's worth highlighting, thinking about. So if you have trouble with the bladder or the bowel, either unable to pass urine or unable to sense when you want to pass urine, or likewise the bowel not working properly, diarrhea, or even constipation, if you have problems with your blood pressure when you stand up, I think we all get a bit of a head rush sometimes, but if it gets more pronounced, when you stand from a seated position, you suddenly get a fall in your blood pressure, and you may even fall and collapse. If you get other symptoms, such as other neuropathy symptoms, which may come with this sort of autonomic problem, may not be part of it, it's worth mentioning this to your doctor. Another feature is erectile dysfunction, and other things include fatigue, inertia, lack of wanting to do things, feeling full quite early in a meal. These could be symptoms of autonomic neuropathy. So in terms of symptoms, how can you kind of help yourself when you see your doctor? I think the important things to note are, when do the symptoms actually start? And what are they? Do you get pain? Do you get burning? Try and characterize them in your mind. Try and put them into words if you can. It's interesting how often similar words come up from many different people when they have neurological problems. And that tells us that actually this is a true feeling that people are having as a result of nerve dysfunction. So have they come on gradually over days or weeks, or is it months or years? Is there any link to any medication that you had for either to treat your Waldenström's or other kind of medication? How are you affected? Is it sensation? Is it strength? Is it balance? Tremor? Do you get pain? What is the distribution of this? Is it both sides of the body, or is it an asymmetrical problem? And what makes the symptoms worse? Position, movement, lack of movement, fatigue, cold temperatures, and so forth. Does any medication help to improve things? And importantly, how are these symptoms impacting on your function? If you're able to let your doctor know about these things, they can begin to understand and put together an idea in their heads as to what is actually happening and what needs to be done about it. Clearly, something that's progressing very rapidly needs to be dealt with quickly. Something more gradual may warrant a period of observation. So the doctors will want to know the nature, the spatial distribution of these symptoms, the rate of change, effect on function, the different kinds of symptoms that you have. They'll want to look at your medication list. We do have medications, many of us, that can affect the nerves, so it's worth knowing what that is. They'll want to know what your diet is like. Do you have a varied diet? You get all your B vitamins and other vitamins that are good for the nerves. They'll want to make sure, for example, you're not deficient in basic vitamins, such as vitamin B12, which can cause neuropathies. They'll also want to know what sort of toxic materials you ingest, such as alcohol. And when I say alcohol, I mean, very habitual heavy use of alcohol is a toxin to nerves. So if that is happening in addition to other problems, then you can really get into a perfect storm situation. And then other history, such as diabetes, is also very important for them to know about, because diabetes is a real life thing. It happens to many people. It can happen in addition to Waldenström's. So we need to know about that as well. Then a clinical examination should follow. Now, you will see that if you're seen by a hematologist, their examination of the neurological system will be much more basic than that by a neurologist, because they're coming from different angles. But a cursory examination is still possible to see whether you have, problems with, sensation or power or coordination. But there's also a general examination to be done, which looks at, do you have an enlarged spleen? Lymph glands are enlarged. Are there any features of this condition called amyloidosis, such as bruising or swelling of the ankles, etc.? Are there any features of what are called cryoglobulins, which I'll mention in a bit? So the clinical examination is very important, both general and neurological. The next thing then is for some kind of, it's sort of a blame game really. Is there a connection between my IgM problem and my nerve symptoms? And that's a very important thing to rationalize, because if there is a connection and it's progressive, then we can do something to treat that. If, on the other hand, you happen to have Waldenström's and a neuropathy, but they're not connected, then it's actually dangerous to treat the Waldenström's for the wrong reasons, because Waldenström's therapies are generally immunosuppressive, not to have unless you actually need them. And this is, I think, where the coordination and the discussion between a neurologist and a hematologist is very important, because each person understands different aspects of the illness. And it's really important to put things together and decide on whether there is causality. Not always possible to do, but certainly an effort must be made to go into that. So that leads on to some investigations. Well, it's very important to do general lab tests to look for, as I mentioned, diabetes, vitamin level problems, autoimmune problems. In other words, antibodies against our own tissues that are more likely to happen in people with WM. Infections rarely can cause problems such as Lyme disease and hepatitis and so forth, and other inflammatory diseases like sarcoidosis. So general lab tests are important. There are IgM-related tests to look for what are called specific antibodies against neurological targets, testing for proteins that form little globules in cold situations, and that can cause circulatory problems and nerve damage. Testing for things like amyloid. You can do simple tests in the blood, something called the NT-proBNP. You can also test the urine, and just for screening, and this can bring up amyloid if that's underlying and not obviously causing the problem. And then, ultimately one may have to biopsy specific tissues, possibly including nerves, but maybe the bone marrow or other things to seek out what, if we suspect that there is something going on that's damaging the nerves. Nerve conduction tests, or EMG, electromyography, may be carried out as well. This is a bit of a variable feast. Some people are seen in a specialist center where the correct questions are asked by the neurologist to say, look, I suspect X, Y, and Z, and then the guy who's doing the test, the neurophysiologist, will do it in a very, in an expert way. I would say that just general bog standard nerve conduction tests, which are not done with a proper idea of what you're looking for, some proper clinical clues, can be unhelpful. And I think that, so one has to be a little bit careful about who does the test and what question is being asked so that the test is done properly. They are uncomfortable. I haven't had them done myself, but I've seen it done and I've heard descriptions. It does require the application of an electrical current and then the conduction being measured using machinery. And, it depends on your symptoms that you already have. It can be really quite sore or painful. And most people do not like having these tests done, but they can be very important to identify whether there are there's damage to what are called the large fibers. Because if there is large fiber neuropathy, then that's something that does need to be looked into in more detail, because there may be corrective measures and treatments that can be applied. So-called small fiber neuropathies, unfortunately, don't really show up on nerve conduction tests because they're directed at large fibers. And small fiber neuropathies are more tricky. They often cause pain. They often have a looser association with IgM problems and Waldenstrom's. And so, for example, if you treat the underlying condition, they're less likely to respond in an effective way. So the mainstay is often more to do with managing pain using appropriate medication. There are some small fiber tests that you can do, but they're, again, very hit and miss, and not everyone believes that they're workable and believable. Sometimes with nerve conduction tests, one single test is not necessarily enough. You may need subsequent testing after a few months to see what the rate of change is or whether there's a change in pattern. Sometimes we have to sample the spinal fluid to see whether there's extra protein, there's inflammation, or even whether there are cells in the central nervous system fluid. And that can happen in the condition called BingNeal syndrome, which I'll mention only briefly. But you can do specialized testing using special things called flow cytometry to look at the different cells, as well as molecular testing to look for markers such as MYD88, to see whether there is some mischief going on in the central nervous system, which can coexist with peripheral nerve symptoms sometimes. So at our center, we have a low threshold for doing lumbar punctures, but we also have a special interest in this area. And I would say many general hospitals wouldn't necessarily be looking to do CSF examination. Imaging is also important. You may want, you may need an ultrasound to look at nerves, thickening of nerves. You may need MRI scans, again, to look at the spine and nerve roots to see whether there's any compression. And any imaging that's done, especially MRI, must be done before a lumbar puncture. Otherwise, you get false positive results on the scan. Your doctor will decide whether this is needed. Likewise, nerve biopsies, usually reserved for the end because it's an invasive procedure. But as you can see, often done on the sural nerve in the foot or the ankle, where you literally do get, you can look at the nerve directly under varying powers to see whether there is damage there. And that sometimes is necessary. So in terms of actual diseases, well, IgM, as you know, I'm sure, is molecules that circulate in groups of 5. They can target myelin and so-called anti-MAG, myelin-associated glycoprotein neuropathies have been well studied. But it doesn't always mean they're connected. That's the problem. But those who do develop, who have IgM and a neuropathy, about 20% of them will experience disability at 5 years after diagnosis, because there is a link. So about a fifth will have a problem which needs looking at and managing. So what is myelin-associated glycoprotein? Well, it is a neuropathy associated with this anti-MAG antibody, and what that does is it specifically results in the widening of this myelin sheath, which then interrupts the flow of electricity. So it's well demonstrated. You can find it easily by testing antibodies. There are many different ways of testing these antibodies, unfortunately. The most reliable way is the so-called Bullman anti-MAG test. And in that circumstance, the high level of greater than 70,000 is most likely to be clinically significant. Many people have lower levels that are less specific. And a few people actually have antibodies and don't even have IgM. So there's always, one has to be a little bit careful. But you can see that they do cause this attack of the myelin sheath, and this causes problems to nerve conduction. Who gets treated? Well, not everybody, to be honest. It depends on whether there's significant progression of disability. And that's something that has to be taken on a case-by-case basis. We don't know to what extent we need to treat patients with anti-MAG. In other words, do we need a very deep response and getting rid of every last bit of anti-MAG antibody to get the proper reaction that we need? The answer is, even if we did, that's really not practical, because most treatments in Waldenstrom's and IgM diseases don't produce a complete response. And quite often, treatments like rituximab or other therapies can reduce the amount of anti-MAG enough to cause an improvement in the well-being of the nerves. So quite in most cases, stability rather than dramatic improvement is the outcome. But obviously, the less nerve damage there is already pre-existing, the better the outcome is likely to be. You can use various treatments. I'd say rituximab is one of the most likely used. It's more targeted, but sometimes people are given combinations of therapies if they also have underlying Waldenstrom's, because then you can treat the condition in a more definitive way. And of course, ibrutinib and similar drugs are showing promise in these areas as well. There have been a few studies being reported, and there is a plan to consider a zanubrutinib trial, hopefully in anti-MAG neuropathy. So we shall wait to see that. So really, all of the above can work in this setting, and no one really knows what's the best way to do it. And really, the buildup of experience in these areas is what's helping us to understand. And each patient does need their own solution, to be honest. Unfortunately, there are quite a few people who have neuropathies without anti-MAG, which makes things even more complicated, because this is a mixed picture of variants. The clinical features and the kind of electrical features vary, and that makes further research very difficult. They may or may not have antibodies. There are a number of antibodies that do exist, which are not MAG, and most neurologists will look for those as well. There are some well-known entities such as Canamad, in which there's a series of clinical features which accompany M proteins and a few other things. And it's important for those to be picked up, because then we can make a link and consider whether treatment is necessary. So I just mentioned this because unfortunately MAG isn't the whole story, and even when there's no MAG and a neuropathy, it can be quite tricky, but nevertheless needs to be looked at if you have progressive neuropathy. WM itself, you can get neuropathy by the same sort of mechanisms, but perhaps also infiltration by this lymphoma cells that can happen to nerves both centrally and peripherally. You can also get deposition of amyloid and cryoglobulin, or you can get those blood vessels that I showed earlier. If they're damaged through various mechanisms, then you can get progressive problems. So you can get demyelination, you can get axonal problems with WM, and of course, one does go through a series of steps to look for the potential causes. We have to treat the underlying lymphoma if you have Waldenstrom's associated or accompanying neuropathy, using the usual kind of suspects. And again, it has to be a case-by-case decision. BingNeal syndrome is when you get central nervous involvement by Waldenstrom cells. This is another whole topic on its own, to be honest, but if there are symptoms emanating from the brain, then that it needs to be identified, because the treatment is a little bit different. One has to perhaps target the central nervous system a bit more closely. The good news is that many of the new therapies, such as zanubrutinib and ibrutinib, do target the central nervous system. But again, if there are symptoms of brain misfunction, could be anything from headaches to loss of memory to even stroke-like events, and you have WM, it's always worth having someone check you out in case BingNeal is playing a part. It's very rare, I must add, but it's just a pointer there to be aware of. I'm near the end now. Cryoglobulin is this odd condition where IgM can form little globules of they just sludge up basically the blood vessels in cooler situations, and they clump together. They cause restriction of blood flow, and you can see this can be varying in effect. You can get also spasm of blood vessel like Raynaud. You can get loss of circulation, funny blotchy changes. You can also get these sort of rash-like appearances, and in extreme cases, you can get ulceration of the skin. The type 1 is most common, and again, needs to be looked for carefully using special blood tests that need to be kept warm before they are analyzed. Similar sort of treatment approach in these settings, sometimes a slightly different approach using immunosuppression. Again, the main thing about cryo is to pick it up so that we can address it specifically. Amyloid is, as I mentioned, this misfolded protein that can cause deposition in various tissues. In this context of the nervous system, you can get nerve symptoms as well as autonomic symptoms. Again, very important to pick this up because it needs a very specific approach to treatment. It needs quite an aggressive management. The main thing is to suspect it. There are many ways of biopsying various tissues. We try and avoid doing invasive tissue biopsies, but in fact, you can see here that tissue biopsy can help. You get this funny appearance here of tissues where it builds up, and then you can do special stains to look for it. And the treatment is basically to support any organs that are impaired, as well as targeting the underlying lymphoma or IgM disease. And that is really my last slide. So to conclude, you can see that IgM and WM can coexist and can affect the peripheral and central nervous systems in many ways. And there are, however, effective therapies. The key thing is to make a prompt and accurate diagnosis so that you can get timely, appropriate treatment. Thank you for your attention.
Thank you, Shirley. I've got a couple of questions that have cropped up in the chat line. So the first one I'm going to ask you is, you talked about the BTK inhibitors. Are any of those been shown to work better for IgM anti-MAG neuropathy than another? Maybe it's too soon to say, I guess, because they're quite new.
Yeah, Bob, it is a bit too soon. I mean, I think at the moment we're at the stage where there have been reports of it working in anti-MAG settings. Probably patients have previously received rituximab. That doesn't necessarily mean they work better. Sometimes different mechanism drugs work differently in different patients. It also depends a bit on whether there's a burden of Waldenstrom's or whether you're dealing with relatively minimal clonal cells. So in the MGUS setting, it would be quite difficult to access ibrutinib or similar drugs because that's really only licensed for the Waldenstrom setting. So yeah, I think it's early days, but it does show excellent promise.
Okay, and a question that was sent in earlier was, who is best qualified to distinguish the cause of peripheral neuropathy? Do you need to see a neurologist? I think you've alluded to that, but perhaps you could answer that.
Yeah, I think it's really important. And what I would say is that ideally you need to see a neurologist who specializes in peripheral nerve disease, because I have learned through my workings with my neurology colleague that unless someone has a good idea of the ins and outs of IgM-related problems and paraproteins and knows how these conditions can evolve, it's sometimes difficult to get to the root of the problem. Now, we have a joint clinic, and we actually get referred patients by many neurologists who are general neurologists who've reached the limit of what they have tried to understand. And they do an excellent job. They work in general hospitals. They see lots of patients come through the door with a variety of problems. But they do reach sometimes a limit with the peripheral nerve problems. So I think ideally seeing someone who specializes in peripheral nerve disease is preferable if you can.
Okay, thanks. Another question from the chat box from Paul Golding. If you're a WM patient and have been diagnosed with sensorimotor polyneuropathy that is primarily axonal, is it possible or likely or impossible that the PN and WM are not related? And if so, would treatment for WM affect the peripheral neuropathy axonal condition?
So yeah, axonal neuropathy alludes to the fact that the actual wire has been damaged. It can be the consequence of a previous demyelinating process, to be honest. If you have enough demyelination, so if you think about, it's a bit like a wire, if you have a wire outdoors, say, and it's got its plastic insulating thing, but over years and years, that gradually breaks up, cracks up, and so on. Eventually, the wire inside, which is metal, will rust. And so that's the equivalent of axonal damage. So the same sort of problem happens when you have progressive demyelination. Over time, eventually, the axon itself can become damaged. And to be honest, once axonal damage through whatever cause has been established in a big way, that can be very difficult to claw back from, because regeneration of nerves takes a very long time, assuming you've switched off the problem that's causing it in the first place. So it's not the end by any means. I think it can be the consequence of prior demyelination type problems, but you can also get axonal damage in the setting of cryoglobulinemia, vasculitis, amyloidosis, because the mechanism of attacking the nerves is a little bit different to demyelination. So it is very important to distinguish and understand, and that's where nerve conduction tests can help us to see, is it primarily demyelination? Is it primarily axonal? Because that also helps us to understand the cause of the problem. But yes, if at the end of the day it is felt to be related to Waldenstrom's, then it's worth treating, especially if it's progressing continuously, because we don't want further axonal damage to happen. It's better to stop the process at that point. And even after treatment, to be honest, I think the body is actually quite amazing. There's a lot of compensation that can happen. So all is not lost. I think the key thing is to get a specialist opinion and, get clear in your mind what is the problem and what the chances are of some improvement.
One off of the screen here, can you explain the connection, if there is one, between restless leg syndrome and peripheral neuropathy, and can you have both?
Yes, I believe you can. I mean, it's not uncommon, restless leg syndrome, and I think, to be honest, it's much more something that happens in normal life. I think it happens in very much in non-WM settings very commonly. And it's got a number of causes, I think many of which are not fully understood, but some of the more standard medical problems can be associated with restless leg syndrome, such as diabetes, other things like lack of rest, sort of stress. Some people have a tendency to have restless leg. I think I've observed that some people in families often have restless legs. So I think it's multifactorial. I wouldn't sort of say that it specifically stands out as a Waldenstrom's related problem. I think it probably coexists, and it may just be a bit more obvious if you have a neuropathy, because if you think about your nerves, they can only speak in a certain few languages. So if you tend to have restless leg syndrome, if you have an added sort of nerve problem, you're quite likely to be a bit more restless than normal. So there are some, there are websites to just advise on how to manage restless legs. I mean, you sometimes can use medication for it, but I would say that that's only really done when it's quite a severe problem, because medication that turns the volume down on nerves tends to have potential for side effects. So I wouldn't call it a WM defining symptom in terms of neuropathy, but it certainly is pretty common.
Okay. A question from Alison has just come in. So many of the symptoms are like Parkinson's disease symptoms. How can you decide the cause if the patient has both Parkinson's disease and WM?
Well, I've actually witnessed this being done by my colleague Professor Lung, because he's a bit of a master with neurology. There are subtle differences. So the tremor of Parkinson's is different to the tremor of anti-MAG. So so it depends on whether the tremor happens with activity or at rest, whether it's in this plane or this plane. There are very important clinical features that help to distinguish the two. There are other features of Parkinson's that help to set it aside, such as sometimes people lose the details of their facial expression. They have slower movements. They tend to be a little more stooped forward. They may have difficulty starting to move. So there are some clinical features of Parkinson's that do set it aside. But if you have both going on, there is something called a DAT scan that can be done to look at the basal ganglia, which is the bit of the brain that's affected by Parkinson's, but not so affected in the setting of WM. So that's a scan that can be done. Sometimes we do recommend some anti-Parkinson medication if there is enough features there to suggest that Parkinsonian activity is going on. Sometimes there are two things going on, and it may be that if you try some anti-Parkinson medication and it helps the patient to feel less unsteady, etc., then it's worthwhile doing. But it would be something that would be a trial, and if it doesn't work, then you must take it away again, sort of thing.
I think we've got 1 minute left, Shirley, so I'm just going to ask you the one on the screen. Does WM-related peripheral neuropathy usually progress symmetrically? Does it start suddenly, or can it be gradual? And what about if it's only on one side?
Yeah, good question. So it's typically the most common form is symmetrical. It's usually what's called length dependent. So it starts usually in the toes, makes its way up to the knees. By the time it hits the knees, your fingers start playing up, because that's the length of the nerve then. So that's usually the demyelinating setting. You get a symmetrical, length-dependent neuropathy that starts at the ends and comes more proximally. If it's asymmetrical, we begin to wonder whether there's another mechanism going on, such as amyloid or cryoglobulin or vasculitis, because those diseases can be a little less, they can be much more, they just pick on different bits of the nerves for reasons known only to themselves, whereas an antibody-driven damage tends to go throughout the body and causes damage in a different by that way. So unfortunately with WM, you have to keep your eyes open, because anything is possible. I'm not saying it all happens, but it is possible. It does need careful review and an algorithmic approach, really. And there are guidelines actually, which were published a few years ago, which do offer doctors that approach. So if you see a doctor who doesn't quite know what to do, say to them, there is this guideline and there's an algorithm available for them to work their way through to try and rationalize what's going on.
Okay, Shirley, well, I think that's us come to the end of our session. So just want to say a big thank you personally to you for what you do for us here in the UK, but also internationally. Thank you for tonight. Very interesting talk, and I hope everybody got something out of that. So thank you very much for your time.
Thank you all. You're very welcome. It's always a pleasure to speak to patients and carers, because that's who it's all about.